ICD-10 and documentation for hospitalists. ICD-10, when compared to ICD-9, is going to be greater in detail, severity, complexity, comorbidities, complications, and any other things that are directly related to the patient's condition. Things that need to be considered when documenting for ICD-10 are things such as the stage of the grade of the disease, unilateral or bilateral conditions, acute or chronic, mild, moderate, severe, the specific anatomical location, whether the condition is controlled or uncontrolled, the root of the problem, and if it's the initial or subsequent visit. Just a quick example of ICD-10 versus ICD-9. In ICD-10, there's a maximum of 5 digits. In ICD-10, there's a maximum of 7 digits. ICD-9, for example, a closed fracture of the femur, you have 16 codes to choose from. In ICD-10, you have 1,530 codes to choose from. In ICD-10, there are 7th digit extenders and placeholders. Pressure ulcers, when you're documenting this for ICD-10, it's very important that you include the laterality, the anatomic location, stage, whether it's healed or not, and unstageable, and the BMI of the patient. HIV, if the patient is coming in with anything related to the HIV condition, that needs to be noted in the chart because that will determine the sequencing of the codes. If you do any type of counseling with the patients regarding this, that also needs to be documented in the patient's chart. Sepsis is practically the same as it was with ICD-9, just one or two few exceptions. When documenting sepsis, we need to make sure that we're documenting the underlying infection, if we know that, any organ dysfunction or failure related to the sepsis. And one of the main points is we can no longer simply state urosepsis. That is no longer an option in ICD-10. Diabetes in ICD-10 is no longer stated as controlled or uncontrolled. We need to know if there's any complications or manifestations. If the patient is type 2 diabetic and they are using insulin, that must also be documented in the patient's chart. And then any underlying conditions need to also be noted. Hypertension in ICD-10 is no longer documented or stated as controlled or uncontrolled. There are many complication codes with ICD-10 with hypertension. And we also need to know if there's any relationship between other diseases, such as hypertension with heart failure. And they would also like to know if the patient smokes or if there's any exposure to smoke. Hypertension with heart disease, kidney disease, hypertension with heart failure, and chronic kidney disease are related, and we must know what type of heart failure and the stage of the kidney disease. So speaking of the heart, we need to know whether the heart failure is due to an underlying condition so that we know the sequencing of the codes. As in the previous slide, is it due to hypertension, hypertension with chronic kidney disease, rheumatic heart failure, following surgery, or any other complications. Heart failure is based on if it's the left ventricular failure, systolic, and then we would need to know if it's acute, chronic, or acute unchronic, diastolic, is it combined? In ICD-9, there was a code for congestive heart failure. In ICD-10, The only option that we have, if we're going to use that, is just unspecified heart failure. This kind of shows you the difference of the codes that we could choose from in ICD-9. And as you can see with ICD-10, we no longer have congestive heart failure unspecified. That code is now just simply heart failure unspecified. COPD, we need to know if it's chronic or acute exacerbation. If it's with acute lower respiratory tract infection, if so, specify the type of infection. Is it with asthma? And again, this is something else with ICD-10. They're really wanting us to document if there's any tobacco use or exposure. Respiratory failure is different with ICD-10, whereas they would like to know acute, chronic with hypoxia. Basically, if they're having respiratory failure with any other symptoms or anything else going along with it, they would like for that to be documented. Pneumonia. Basically with pneumonia, they would like for you to be as specific as possible. So if you've had the test results come back and you know exactly the specific type of pneumonia, that would need to be noted in the patient's chart. Otherwise, it would just be coded as pneumonia unspecified. Reason for admission, when we're documenting that in the patient's chart, it needs to be very clear. Whether, especially if the patient is outpatient and they're going to switch to inpatient. That helps with medical necessity. It also helps with readmissions and any type of claim denials to try to prove why the patient was outpatient for maybe 2 or 3 days and now they have to be converted to inpatient. Basically with documentation, there needs to be a clear plan. So listing problems without a clear plan of care can cause downgrades, downcoding on your charts based on the patient's diagnosis. Listing problems with brief, generalized comments such as just diabetes, chronic kidney disease, congestive heart failure, and you just basically state continue with current treatment. This also could cause the complexity of the patient's chart to appear lower, so it could cause downcoding of your chart. Your plan needs to include problems that the physician's personally managed along with any other physician. So if you are managing something that maybe cardiology is also managing, you need to make sure you document that in your patient's chart. Credit is given for the quantity of problems managed as well as the quality. Your documentation should always identify any problems managed or addressed during each encounter. Remember that when we're looking at progress notes and a coder is looking at those, or an auditor or whomever, each one of those notes should be able to stand alone. So by looking at each individual note, we should be able to know what type of care you have given or is ongoing or is continued with that patient. You need to also identify any problems. You need to identify them as stable, progressing, improved, worsening. If there's any differential diagnosis, indicate the management and treatment options for each problem. If your management option is something such as continue current medication, you should list the medication instead of stating continue current treatment or continue current plan, because as I mentioned in the slide before, this could in some cases cause your progress notes or your levels to be downcoded. Some new concepts to think about with ICD-10 is we need to try to avoid unspecified codes unless we have absolutely no other choice. There's going to be some situations that maybe we have no option but to use the unspecified code. But those need to be as minimal as possible. Initial and subsequent encounters for injuries, fractures, and any related external causes. But if we take ICD-10 and we compare it to ICD-9, it's estimated that about 50% of the required documentation for ICD-10 is already required in ICD-9. 50% is laterality, whereas in ICD-9, we would just add modifiers right and left. But in ICD-10, these are included in the codes. But of that 50%, only 10% of that is new. So if you break it down with those numbers, ICD-10 doesn't seem so scary as it did in the beginning when everyone first started talking about the changes and things that were coming with ICD-10. Most documentation changes are within the musculoskeletal section, and about 36% of that change, again, involves laterality. So, to sum up the presentation, we need to be as clear as possible with ICD-10. You need to just make sure you're putting everything that you have done for that patient and with that patient in your progress notes or your H&P. Try to be as specific as possible so that the coder can avoid using unspecified codes. And as long as all of that is being documented, the coder can take care of the rest, and ICD-10 doesn't seem so scary. Thank you for listening to this PowerPoint presentation. If you have any questions, my contact information is at the end of this slide, and you can contact me.